y'all, this is Katie Bodine, and I just wanted to go over a few points with obesity. If you watch the metabolic syndrome lecture, it's very redundant with the overall treatments, but let's just go ahead and define obesity for the principle of thoroughness. So the definition, again, we know that it's one of the most common disorders in medical practice. It's also the most difficult to manage, okay? It's defined by an accumulation of visceral and subcutaneous fat. We measure this by using the BMI oftentimes, and literature still goes by BMI. You've heard me say this before. It's not entirely accurate, but it's a good screening tool, okay? And insurance still utilizes it. It was invented a very long time ago in a very different demographic. So I think we need to use a little common sense. And if you need to define BMI or your percentage of actual lean versus fatty body mass, DEXA scan is the most accurate, believe it or not. But in any case, most people you can screen easily with the BMI. You can easily calculate this with any medical calculator, and you simply divide the measure body weight in kilograms by the height in meters squared. Again, use your clinical calculator. It's that easy. And obesity is defined, and you'll see this again, it's defined as a BMI over 30 kilograms per meter squared. Picture's worth 1,000 words. So the NIH defines various BMI levels. And your normal BMI is 18.5 to 24.9. So we are technically overweight once we get over 25, BMI of 25, okay, and just under 30. And then we have class 1, 2, and 3 obesities. In terms of obesity, the distribution of fat does matter. So your upper body obesity, this is your abdomen and flank area, it has a greater health consequence than lower body density obesity. These are the people who carry their weight on the lower halves, their buttocks and thighs. And we have hazards or risks associated with when our upper body obesity, i.e. our abdominal circumference, exceeds 40 inches in men and 35 in women. Okay. There is a greater risk when you have the higher waist to hip ratios, but visceral fat in the abdominal cavity, you can have sarcopenic obesity as well. Subcutaneous fat around the abdomen, or people with lower muscle mass can still be technically obese if they have less muscle and a larger belly. So here's just another picture worth 1,000 words. You can see that we have, it's easy to remember it if you think of the pear-shaped fat distribution versus apple-shaped, okay? We talked about the central truncal obesity, and it's a pathophysiologic effects with metabolism, and in our metabolic syndrome lecture, so I won't beat that one to death. In terms of epidemiology, the prevalence in the United States is over 42% of Americans, and it's costly, folks. With the secondary disorder, we're spending billions of dollars on consequences of obesity. In terms of demographics, this is changing slightly. The most recent for the CDC, they've got a nice visual map of obesity in the United States, and it's more prevalent in the South. It's more prevalent in women, and it's actually more prevalent in Hispanic Americans, followed by non-Hispanic Black Americans, followed by non-Hispanic white Americans, and non-Hispanic Asians. The highest risk recently with children seem to be highest in Native Americans at 19%. I don't have that on this slide. People of low socioeconomic status, they don't have access to cheap, healthy fruits and vegetables, right? So having low socioeconomic status is a big reason. And then there tends to be a trend in higher educated, versus lower educated individuals. We talk about etiology again. There's nature versus nurture, right? So there are genetic factors involved. They've done twin studies, and they can have a variation in BMI among twins. They do find genetic and phenotypic changes, and there's a great lecture by Carly Burge. We'll put that podcast in the back of this lecture because she does a phenomenal job explaining different phenotypical issues or contributing factors among people diagnosed with obesity. And so there's very much a multifactorial reason for this. And there are genes identified. And then there's environmental factors, right? Our culture. So there's been a very rapid recent, in very little time, just a few decades. And this really points to environmental and behavioral factors, right? So we didn't see a lot of obese people in the 60s. So obesity is associated with a significant increase in both morbidity and mortality. And many disorders occur with greater frequency in patients with obesity, as we discussed in the controversial syndrome, metabolic syndrome, right? So most of these people, they're higher healthcare. It's because of the insulin resistance syndrome. They are developing type 2 diabetes, hypertension, hyperlipidemia, higher risk of cancer, arthritis, right? Vitamin D deficiencies, cardiovascular disease, OSA, and asthma. These people will also have a higher risk of thromboembolic disorders, this higher rate of inflammation, which is also associated with cardiovascular disease. They will have a more skin disorder, GI issues, i.e. gallbladder disease, GERD, right? You've got pressure in the abdominal fat pushing up on that stomach and subsequent pressure on that lower esophageal sphincter. So you're going to get acid reflux, okay? People with obesity also have a higher risk of pulmonary functional impairment, including sleep apnea and obesity hypoventilation syndrome. There's associated endocrine abnormalities. I don't know which one caused which, but I think there's a lot more research to be done here. There's also increased rates of major depression and binge eating disorders. And even though our social stigma has improved a little bit, there's still significant social stigma against people with severe morbid obesity. I really like this illustration from Current Medical Diagnosis and Treatment, and it demonstrates the role of obesity in the pathophysiology of disease. So it shows that in some ways obesity contributes to disease, and the short arrows refer to the change in the indicated parameter, and the long arrows will indicate the consequence of that change. So you can see in some cases the evidence is epidemiologic, and in other cases experimental. So this is a reproduction actually in McGraw-Hill, but from permission from Pathophysiology of Obesity in the American Journal of Clinical Nutrition. Our obesity evaluation is going to be no different than our view at people with suspected metabolic syndrome. We were going to be doing a very thorough review of systems, a very thorough social and family history, psychosocial history, and looking at any medications that they're on that may be contributing, and reversible factors. On physical exam, we're great clinicians, so we're going to take great care in picking up on any syndromes, which are rare, that secondary causes. But if we have an enlarged thyroid and symptoms of hypothyroidism or Cushing's disease with that classic buffalo hump or striae, we are going to have a higher suspicion of a secondary disorder. But by far and large, most people this is a lifestyle issue. So to take into consideration their nutritional status, again, secondary causes, and we're going to be looking for those comorbid associated conditions related to weight, diabetes, cardiovascular disease in particular. So our diagnosis is simple. It's a BMI greater than 30. And so we will screen everybody for comorbid conditions. So you're going to be looking at the CMP. Everyone should get a lipid panel. We should be making sure their triglycerides aren't exceedingly high. They should get an A1C even if they're already on metformin. Also a lipid panel if they're already on a statin to ensure it's working. Other labs as indicated, if they have a high fasting glucose, we want a urinalysis and make sure that they're not having albumin spillage. And then we want to, again, utilize our clinical gestalt on working up other issues of secondary cause. Our treatment is going to be the same as in our lecture on metabolic syndrome. We really want to focus on lifestyle modification. First line always is obtain a clinically relevant weight loss. We need to reduce this BMI, and if we can get 7%, that's the average of 5 to 10, we can actually improve risk factors. And at 1 year, it's associated with significant improvements in blood pressure, glucose, triglycerides, and HDL cholesterol. So it oftentimes requires a multidisciplinary approach. If you have the opportunity to utilize those resources, unfortunately, not a lot of people can afford a dietitian and a gym and all these things, but there are plenty of ways that we can make other adjustments. Our cornerstones are still going to be diet, activity, and behavioral modifications. Again, so lots of dietary strategies can be effective for weight loss, but each individual patient is special. So we need to individualize our care and allow for wiggle room. We need to, you can't just use a hard fast diet. Everyone needs to be on a Mediterranean diet. There's people who just don't like those foods. They will not eat them. Okay. So we need to emphasize staying away from unprocessed foods. Stay away from empty calories, right? Chips. We need to, if we can, refer to a dietitian, but we need to tailor our options to the patient preference. Not everyone can just do intermittent fasting. I know people who get really hangry. Okay. We also need to focus on behavioral modifications. Okay. Somebody has a habit of watching TV and then hitting the fridge. They need to move their chair or stop watching TV at that time, maybe go on a walk if they feel that urge, things like that. There's some simple solutions. Having them do some self-monitoring. When are they binge eating? That might give us some cues on how to help them. Exercise is great. It helps with maintaining weight loss. Obviously, aerobic exercise is going to increase our daily energy expenditure, and it's good for maintenance. It helps preserve lean body mass. It helps increase our muscles. It, decreases our basal energy expenditure. It helps us mentally, right? So, unfortunately, compared to no treatment, exercise alone leads to a very minimal amount of weight loss. You cannot go to CrossFit for 30 minutes and burn, 500 calories, and then go eat a fried pork tenderloin sandwich covered in gravy. That's 2,000 calories. Okay. So there really needs to be exercise and diet together. And I don't believe in diets. I believe in moderation. But some people do need strict dietary guidance. Okay. Telling somebody to go out and get 150 minutes of exercise a week is overwhelming. Okay. So maybe help them by saying work out 10 minutes and take a break. Cumulative minutes of exercise per day, so 10 minutes here, 5 minutes there, 20 minutes there, is beneficial. In terms of treatment, I will put out another lecture that specifically looks at medication management, but we also want to review what medications people are on. There are a lot of medications that can cause weight gain, okay? So they are variable and they can be unpredictable and they can be individualized. So corticosteroids are a high rate of, especially if they're long-term, like somebody with autoimmune disease, weight gain. Contraceptives, a lot of psych meds will cause weight gains. Some of the antihypertensives, in particular metoprolol, can also lead to weight gain. So we need to make sure we're looking at people's med lists when they come in. This is a nice list of some very commonly used drugs that can result in weight gain, okay? And the source here is from current medical diagnosis and treatment. Okay, so second line treatment, once we've reviewed medications, we've tried that conservative treatment, we are going to initiate anti-obesity medications, okay? And there are several, as you know, we're getting inundated with commercials and all sorts of FDA approvals continue to be released on pharmacologic treatments for obesity. They were initially aimed at type 2 diabetes, but demonstrated weight loss. So we're going to continue to see these. This lecture, even though it's done in 2023, is going to be outdated by the time you watch it. And so there will be more FDA approved medications, but the GLP-1 receptor agonists, or i.e. semaglutide, also known, brand names are Rybelsus, Ozempic, and Wegovy as a combination drug, but these are shown to have some really good outcomes similar to that of bariatric surgery, but the literature maintains that the next line is actually bariatric surgery. So I'll be interested to see what the ongoing evidence reveals with these medications. In terms of medications, there are a number of FDA-approved medications. There's a really nice list, actually table in UpToDate. If you just search obesity, they'll give you a table and it will divide it by class and then side effects, which I like to see. But there are some oral medications, the older ones were aimed at reducing, regulating appetite. They utilize signals through serotonergic, dopaminergic, or noradrenergic pathways. Okay, they work in the brain. They mostly target the hypothalamus, which promotes satiety, essentially. Okay, and so I do want to note that most of these medications, there are some that are approved for long term, but most of them are really only approved for short term, meaning 3 months at a time. Okay, and I want to also stress that the medications are not a replacement for diet and exercise. They're not an easy fix. They are a supplement until they reach that goal, and then they need to continue with their lifestyle. Otherwise, they will slide back just like bariatric patients do. Again, bariatric surgery is still, by recommendations, current guideline recommendations, bariatric surgery is the most effective treatment for obesity. I do think this is going to change as we see long-term outcomes for the newest and greatest medications that are coming out. There are a few types of bariatric surgeries. There are also less invasive devices, and that will be a patient-centered conversation between the patient and the surgeon, where their best and safest option are. Okay, there are some contraindications, and if they are super morbidly obese, they may not be a candidate. Okay, and if they're a poor surgical candidate, their heart failure is too severe, COPD, you're never going to extubate them after surgery. They have a history of non-adherence to anything, they will probably be declined for that. Okay, and we're still going to have to follow these people pretty regularly.